All right, good morning. My name is Mary Leonard. It is my great pleasure to introduce you to a very special pediatric grand rounds this morning. Just make note of the text code on the left for CME credit. And with that, we'll kick off our session on promoting health equity at Stanford through the use of interdisciplinary case-based rounds. Also want to call your attention to our upcoming grand rounds. Dr. Luce Bertani is going to speak to us about haploidentical stem cell transplantation. You've always got a donor, and largely because of her innovative research. And so why not always use it? We look forward to that presentation. Next slide, please. Also want to make sure everyone's aware of our upcoming Med-Ed Forum on innovations in medical biosciences education on Friday, October 8th. We'll start 8 a.m. to noon. And just to look at the wonderful lineup of speakers and the really great representation from the Department of Pediatrics distinguished educators shown here. And then you can see the registration code. Next slide, please. All right, so it's my great pleasure to introduce Dr. Baraka Floyd, who's going to be leading this session. Sure, many of you know that Baraka is the Department of Pediatrics inaugural Associate Chair for Diversity, Equity, and Inclusion. Baraka has a distinguished track record of community engagement, mentorship, and scholarship in health disparities. In particular, she's a champion for numerous initiatives to support marginalized communities. For example, she was appointed as medical director for the Peninsula Family Advocacy Program last year. This is a partnership between Packard and the Legal Aid Society of San Mateo that addresses legal issues that may negatively impact child health. She also spearheaded the rollout of an inpatient food insecurity screening pilot at Packard and developed postpartum perinatal depression screening and universal social determinants of health screening for all patients integrated into EPIC. At Gardner Clinic, she serves as a mentor to medical students, residents, and fellows. She's been awarded the Advocacy and Golden Apple Teaching Award from our pediatric residents and received a letter of distinction from the Stanford MD program for the quality of her teaching of medical students. Please join me in welcoming Baraka as she introduces today's presentations and the panel. Thank you, Baraka.
Thank you so much, Mary. We are so excited today to bring you a demonstration of health equity rounds. The goal really is to promote health equity at Stanford through interdisciplinary case-based rounds. And I want to first start by taking a moment on behalf of our team to thank all of those in our department who've really blazed the trail in health equity and DE&I to lay the groundwork for the work that is to come. We also want to acknowledge our core values of promoting anti-racism and equity through our policies, programs, and practices, standing in solidarity against racism and intolerance to provide a safe and inclusive environment. Next slide. With our presenters, panelists, and guests today, we'll simulate what health equity rounds might look like in local contexts. Our presenters today are Dr. Guerin from the Office of Pediatric Education, our Health Equity Rounds Inpatient Pilot Lead, Dr. Kameny from Cardiology, Roxanna Van Norman, formerly of MCHRI, and then our Health Equity Rounds Outpatient Pilot Lead, Dr. Cynthia Wong from Nephrology. Our panelists that are joining us today are Liliana Espinosa from Interpreter Services, Kim Browne from Patient and Family Services, Shawn Bickham from Case Management, who may need to step away today for an acute patient care issue, and then Dr. Marlow from Hospital Medicine and Dr. Ruiz from the Pediatric and Intensive Care Unit. Our guests, Benjamin Elkins and Dr. Terry Platchek from Quality and Performance Improvement, are also joining us, and we invite you to ask questions through the chat throughout. We'll attempt to speak to these during the talk or answer them during the chat. And if we have time as we're able, we can answer longer form questions at the end. I'm going to pass it to Dr. Wong to start our presentation.
Our learning objectives for today is to identify and analyze the effects of implicit bias and health inequity in clinical scenarios, employ evidence-based tools to recognize and mitigate personally held implicit biases, collectively strategize ways to make the care we provide more equitable. So ground rules for today, since it can be difficult with some cases that we're talking about health equity, we just wanted to emphasize that this is a safe space to promote learning within a culture of acceptance and growth. We assume good intentions, humility, and understanding, and details of the case have been changed to protect patient confidentiality.
Great, and with those ground rules in mind, we'll delve into what exactly we're doing here today with health equity rounds. So as you'll see through our case today, this is meant to be an interdisciplinary conversation for us to learn from each other and explore issues of equity, bias, and racism and see how they can play out in our medical settings. As we all know, health inequities are really based both on personal and systems issues. And so with these presentations, in addition to delving into the case, we hope to leave you with evidence-based personal bias mitigation strategies. And as you'll see, also some opportunities to affect systems change. We're fortunate that health equity rounds in pediatrics was pioneered by the residency group at Boston Medical Center. This group has been incredibly generous to me and to our group as we've been starting this pilot and getting off the ground. And here at Stanford, some of you have already participated in some of the pilots. There have been a total of 5 in the last academic year at Heart Center M&M, in the CVICU, with the heart failure, heart transplant group, and with the cardiology fellows, as well as with the renal and rheumatology inpatient teams. And we hope that this will embody the future structure as we move this project forward. So we hope that there will be local rounds that are able to deal with the issues in your unit or clinic or practice setting, but also enterprise-wide objectives like today, where we all can come together as a university community and talk about these issues. The innovation that we're adding here at LPCH to layer on top of the structure that Boston and their group pioneered is, in addition to using these rounds as a vehicle for personal education, as you'll see, we also really want to expand that scope, because bias and racism are not just personal issues, but rather are rooted in systems level issues. They require systems level solutions. And so we're engaging with our quality and performance improvement teams to mitigate some of these underlying systems as well.
So what is the role of quality improvement in health equity? So health equity has been identified as one of the key pillars of quality, and we need to leverage opportunities to advance health equity efforts whenever possible. To help form a framework of where to start, quality improvement can be used as a tool to advance health equity by identifying disparities and barriers to care for specific groups. Quality improvement can be utilized to bridge the gap in quality healthcare and recognize that using a one-size-fits-all approach can actually widen disparities gaps. Many QI interventions are developed without assessing the potential effect on disparities of care, which emphasizes the importance that QI needs to engage leaders, staff, patients, and families from various backgrounds to ask for their views on unintended consequences of an intervention that may actually worsen disparities in care. We need to address system issues and barriers and tailor quality improvement efforts for each patient population and target the root causes of inequities. We can start by developing culturally responsible QI interventions and highlighting solutions when framing messages around health equity.
So before we get into the actual case and the discussion about what occurred, we wanted to start with a few foundational concepts that will help give all of us a common language and framework when approaching the case discussion. So the first concept that we want to review is the difference between equity and equality. And we have a very brief video that helps illustrate this difference.
I've come to think that most people believe that everyone deserves the same opportunity to achieve good health. That we should all have what's necessary to pull ourselves up by our bootstraps. That we should all be given boots that fit. And that's when I learned the difference between equality and equity. See, one ensures everybody gets the same thing, while the other ensures everybody gets the something they need. Take 3 neighborhoods. Each one is situated across from the grocery store. One has no transportation system, and the streets aren't safe at night. One needs a boat to get there, and one is positioned a block away. Equality says, we hand them all boots and tell them to make do. One-size-fits-all solutions for problems that require more than one resolution. But equity, the quality of being fair and impartial, speaks to access. Equity speaks to safety. Equity speaks to transportation. Equity speaks to understanding. Equity speaks to the actual human condition.
So as that video illustrated, there's an important difference between equity and equality. And just to re-review the difference between these different terms. So equality is really about distributing the same resources and opportunities to every individual in a population, and it does not account for disparities. So in the graphics below, you can see for equality, everyone gets the same type of bicycle. But in equity, this is a more customized distribution of resources and opportunities, and it's specific to each individual's needs. So it does account for disparities as shown by the graphic. And really health equity is the goal that everyone has a fair and just opportunity to be as healthy as possible. But due to a range of various social and economic factors, good health can be hard to achieve or maintain for certain individuals. And so the goal really is to eliminate these disparities in health among these disadvantaged groups.
So the second concept we want to share is around bias and how that may impact folks in certain contexts. Bias is prejudice in favor of or against one thing, group, or person compared with another, usually in a way that's considered to be unfair. The first on the left side is explicit bias, and this is the kind of bias that we're probably most familiar with. With explicit bias, we are conscious, will self-report certain biases, and aware of how our biases influence the decision-making. And on the right side of the slide, you'll see the second bias, implicit bias, which is based on learned stereotypes and prejudice that we've accumulated over time. This leads to automatic assumptions, and we become unconscious in our thinking and influences in our decision-making. And because we're unaware of this influence of biases will have on others, it's often difficult for us to change. And there have been studies that have shown that implicit bias in patient care has had negative impact on the quality of care that patient receives, and negative stereotypes about minority held explicitly or implicitly by physicians can contribute to healthcare disparities in a multitude of ways. And this can include patient delay in seeking care due to concerns regarding how they will be treated, or worse compliance with treatment due to communication and trust. So understanding our biases can help us understand how it impacts patient care. In the next slide, we also want to explain the dual process theory, and this is an important theory that helps us to understand how our brains work, particularly in a clinical context. The first is system one thinking, and this is the fast thinking, particularly again in clinical context where we're often working really fast, overwhelmed with a lot of information and under pressure. And over time, it becomes automatic, and we rely on pattern recognition to confirm, deny our beliefs in a certain situation so that we can make decisions quickly. On the right side, on the bottom side of the slide, is systems two thinking, which is more slow when we're actually in a deep concentration and we're much more deliberate in how we see a situation. Again, working in a fast-paced environment can put us in a place where using system one thinking a lot of the time in making our decisions. And again, this is where implicit bias can impact the quality of care that patients receive, again, based on learned stereotypes and prejudice and automatic assumptions. And so it's important to recognize that we're making decisions quickly and understanding the influences of a bias that can have on the patient care.
So now, as we take a step back, we think about the fact that racism in and of itself is a system. It's a reinforcing system. Despite race being a social construct, we start over on the right side with stereotypes, biases, and stigma, and those help shape and reshape social forces ranging from historical events to political and economic structures. Cultural racism is really the way in which inferiority of different groups of people, particularly peoples of color, when we're talking about racism, becomes embedded into belief systems, becomes embedded into norms, and that drives widely held negative beliefs that marginalize populations of color. Institutional or structural racism compounds upon cultural racism, and this acts through societal structures that decrease access to opportunity and resources. So residential segregation and creating food deserts, for example, or poorly resourced educational systems is an example of institutional racism. Then when we go down to individual discrimination, this really describes the process of differential treatment of people of color felt from institutions and individuals. Action at these three levels structures opportunities, providing differential access to opportunities, freedoms, and saps individual and collective resources, through inefficient use of social resources. So, for example, lack of access to quality education can drive income disparities and has negative effects on health outcomes.
Another thing that can affect health outcomes is health literacy. So health literacy is defined as an ability to obtain, process, and understand basic health information and services needed to make appropriate health decisions and to access and navigate the healthcare system. Health literacy is intrinsically linked to both an individual's and a community's socioeconomic context and is a powerful mediator of the social determinants of health. Over 20 years ago, Congress identified health inequities and requested that the Institute of Medicine assess the extent of racial and ethnic disparities in healthcare and identify potential sources of disparities and suggest interventions. So in 2004, the Institute of Medicine published the report from their work that was Health Literacy, a Prescription to End Confusion. In this report, they identified 90 million adults, or 1 in 3 adults, have trouble understanding and using health information to properly follow medical advice. So as shown on this slide, the CDC also showed that patients with low health literacy are more likely to visit an emergency room, have more hospital stays, are less likely to be able to follow treatment plans, and have higher mortality rates. So this report highlights to improve quality of care and reduce disparities, we need simultaneous improvements in health literacy. But because health literacy is a system problem, not a patient characteristic, interventions need to meet people for where they are and to address the root causes. For instance, a complex text for instructions must be simplified with attention to culture and language using graphic representation when appropriate. We also need to commit to health literacy training and align healthcare system demands and complexities with individual skills and abilities. Next slide. So health literacy skills are mediated by a person's education, culture, and language. Adults who speak a language other than English before entering school and have limited English proficiency have lower health literacy than native speakers. The definition of limited English proficiency is displayed on this slide. And limited English proficiency may contribute to and exacerbate the health consequences of low health literacy.
Now we're going to toss it to Dr. Marlow, who will share with us at the beginning of her case.
Thank you, Dr. Floyd. So this was a patient we took care of. She's a 9-year-old girl with a rare progressive neurodegenerative condition. And she was really admitted to the hospital for persistent aspiration or choking risk and a need to establish a safer, more permanent way of getting nutrition because she was having very poor weight gain. In consulting many specialists and working together as a team with the family, the decision was made to connect a tube directly to her stomach, so place a G-tube to really create that safer route for nutrition. It's worth noting family history. So the family is originally from Yemen and Arabic is their preferred language. Sadly, the patient's older sister actually died of the same condition several years prior. And so when this patient was diagnosed, the family did everything they could to identify the best medical care. And they actually immigrated to the US in order to get that care. The family currently lives in Monterey County. In the home is the patient's mom, dad, and older brother, as well as the paternal uncle. Again, to kind of demonstrate the context in which they came, the patient's 18-month-old brother is still in Yemen. Mom is the primary caregiver because dad's work is overseas, and so he's often gone for extended periods of time. And unfortunately, during the hospitalization, he was not always available via phone as he was in quarantine.
Liliana, from an interpreter's perspective, what kinds of barriers do you anticipate for patients and families with limited English proficiency? And how might you take into account the role of cultural values?
Thank you, Baraka. In this initial case presentation, as an interpreter, I can identify several barriers. The key to a successful hospitalization and ongoing medical encounters starts from the admission process, where language access can be secured and established to provide continuous on-site interpretations, preferably in person for short and long-term goals. If and when the correct language service is facilitated, compliance and follow-up will never be an issue. It is necessary to have an interpreter for at least once a day medical update. teaching sessions using the teach back method to ensure everything is fully understood. In this case, it's the G-tube. And of course, interpreter needed for discharge instructions. Instructions. If there is an option for in-person or iPad phone interpreter, always pick in-person. Also, while provider and an interpreter are present in a medical encounter, never hold the interpreter responsible for what the patient says or doesn't say. Remember that the interpreter is the medium and not the source of the message. And lastly, being aware of cultural norms around gender and ethnicity. In this case, mother of the patient may feel disempowered to speak up and question the provider, therefore less inclined in the medical decision-making. Whenever there is a need to close the gap of communication, the interpreter can be a powerful and useful resource to further assess the differences in communication styles between various cultures. And referring to the values, cultural values, I think honoring language access, beliefs, social roles, customs, traditions, and respect for one another is vital.
So Liliana, it really sounds as if as you're working with families, you're really trying to align what you're providing with their very specific challenges and needs.
Yes.
Applying an equity lens.
Correct.
Kim, I know trauma-informed care is a really important way that we can meet patients where we are or where they are. How would you apply trauma-informed care here?
So for anyone who may not have familiarity with the concept of trauma-informed care, this is a strengths-based framework with underpinnings in really having an understanding of and a responsiveness to the impact of trauma, really thinking with a 360-degree lens about physical, psychological, and emotional safety, both for the survivor of trauma and the providers who are interacting with that individual, with the intent of creating opportunities for the survivor to rebuild a sense of control, find a place of empowerment as they move forward. We really shift our perspective from thinking about what's wrong with this person to what might have happened to this person and how can we be of help to help them in their journey forward. So as we think about this particular case, I think it's important to think about the many layers of impact of trauma that this mother and family have experienced. Acute trauma is thought of as sort of a single event that happens, maybe a car accident, whereas chronic trauma is something that occurs over a longer duration of time. Sometimes we see this if somebody has experienced interpersonal violence in their household for a long stretch of time. And I think we have elements of both in this instance. Certainly the loss of their first child is an extreme example of that. And from that, do we know, are these parents experiencing self-blame because now they have another child with the same condition who's going through extensive medical issues as well. We also know that the family originally is from Yemen, where a civil war has been happening for many years. So have they experienced political trauma that is just an additional layer for them to navigate as they are engaging with a medical system? Now mom is living apart from her husband, who's quarantined and is experiencing needing to be the primary decision maker in a context which culturally may not align for her. So how do we respond to all of those circumstances? I think just a handful of opportunities that we have are really empowering mom, giving her choices and asking her preferences. Some appreciative inquiry about what communication style feels most natural for her, how much information does she want to share and with whom, whose support does she want and need in her decision making, that sort of thing, and really allowing space and time when delivering information or asking questions.
So really, Kim, what you're doing here is shifting your lens of trauma-informed care to normalize the experience of trauma and center the patient and the family in their care experience.
Absolutely.
Now I'll invite Dr. Marlow to tell us a little bit more about the progression of the case.
Thanks, Dr. Floyd. So several days into this patient's hospitalization, you come on service. You're pleased to see that rounds are being conducted with an in-person Arabic interpreter, and no significant issues are being identified. But you do feel that mom is very deferential to the providers, going along with anything that's recommended. It's not until later that you learn that mom is illiterate or unable to read, and she's been unable to navigate the directions to the hospital cafeteria or the menu that's provided in the patient room, essentially not eating for days. More than that is that part of this hospitalization occurred over a holiday. And as we know, that can lead to limited in-person interpretation opportunities. And so the medical team was left to rely on very suboptimal options, such as the iPad and phone for interpretation. And this led to fragmentations in care. Ultimately, though, the patient does receive her G-tube, she receives training and meets criteria for discharge. But a couple weeks later, you decide to open her chart and see how her care is progressing. Unfortunately, you find numerous no-show appointments. You see some attempts at medication refills that actually have the paternal uncle trying to carry out the requests given mom's limited English proficiency. She's seen for a telehealth follow-up visit, and luckily she does state her concerns, which is that she's actually uncertain how the discharge feeding regimen was supposed to be set up, and the patient has lost over 2 kilograms in the last month alone. She's also voicing difficulty in obtaining G-tube supplies.
Shawn, I know often as we plan for discharge, planning starts from the day a patient comes in. But can you share with us how you might approach teaching and discharge planning for a family with limited English proficiency to tailor to their needs?
Well, thank you, Baraka, for that question. One of the really important aspects of case management is ensuring that we educate patients about what will be needed post-discharge to help continue to implement the plan of care that was established in the hospital. And so one of the things that I do before going in to begin a case management assessment is that I identify what is the preferred language of the family. But it doesn't stop there. When I get into the room, I like to make sure that I confirm that what is on the chart is in fact how the family wants to communicate, because I think that is the beginning of building trust with the providers, because we are acknowledging where they are and how to best educate them in a language so that they understand the needs of their child. I often attempt to try and use an in-person interpreter once that language is established, because I feel that also brings another level of comfortability with the family while we're trying to establish a rapport and implement these education points for discharge. But I will access the iPad interpreter if that is in fact the only other option, just because I'd rather have some access to their language of preference rather than not. Once the language has been established, I also make sure that we can try and provide literature regarding how to, for example, using Dr. Marlow's example, how to feed through the G-tube, making sure that if they have any questions, we can answer them at that time. We like to present that information in the language of their choice, again, so they can have a point of reference post-discharge. I am also responsible for coordinating the bedside teach with our durable medical equipment companies in home nursing. And at that time, we like to establish again that there is a specific language. And if they can provide members of their team to come and perform those teachings in the language preferred, we find that that is also very helpful in retaining the information for our families. It also helps, I feel it helps prevent the family from feeling incompetent, because they know that they can ask questions with the interpreter there to facilitate those questions on their behalf. When it comes to nursing, I do meet with the bedside nurses who are, we discuss the language, and they make sure that they can provide any teachings that they have to give to the families prior to discharge in that language. And ultimately, this will lessen the chance of a family being readmitted into the hospital because they will have the information that they need. One thing that I have noticed in my practice is for families who are readmitted because of perhaps a language barrier or a knowledge deficit, are sometimes labeled as being non-compliant or in some cases difficult. And I've always cautioned my colleagues to be mindful of the language that we use to identify these families, because it could be something as simple as they're not understanding because it was not presented in their language of choice. And then that also then kind of bleeds into our implicit bias. So again, with case management, we try to make sure we take a holistic approach, including identifying language and providing interpretation when necessary.
Shawn, as I heard you start to mention implicit bias, it made me think about, as an outpatient provider, how when I'm faced with looking at a chart, as Dr. Marlow mentioned, and I see a long list of no-shows, medication refill missteps, it often is frustrating because you as the provider have worked hard to partner with this family to try to assure that we're able to advance their care. But by stepping back and using system 2 thinking to ask families what barriers might be present, then we really can align with the family and assure that they're able to get what they need. This also can help prevent us from putting patients in a position of feeling marginalized by us blaming them for things that actually are issues with systems. I know, Dr. Wong, we've talked a lot about how we get so committed to making sure that our patients get what they need, that when that doesn't happen, it can activate our implicit biases as well. But do you have anything to add?
Yes, thank you. And so actually we had a patient like this where when they were coming to, had clinic appointments, they had many no-shows. And so we realized that we needed to step back, take time and reassess the situation. And we were able to get social work involved. And we found that the patient actually didn't have rides to get to clinic. So the no-show was due to the fact that I didn't ask about whether they had problems actually getting to clinic because they didn't have a ride. So the social worker was able to arrange rides. And since that time, that patient has been able to come to all their clinic visits.
Thanks, Cynthia. I now want to invite our special guests from Quality Improvement and Practice Improvement to share with us some innovations that are coming out of I'll actually highlight our systems level fix for limited English proficiencies that's been coming out of the PICU.
Thank you, Baraka, for the opportunity to discuss and highlight ongoing QI projects based on health equity efforts in our pediatric ICU. I hope this presentation thus far has emphasized for everyone who woke up and tuned in to this session the need for institutional health equity. One of the most critical and most visible forms of health inequity that exist in our hospitalized patients is the lack of support and resources surrounding providing limited English proficient families, or LAP, with health updates, information, education plans, participation in rounds, etc., in their preferred language, which I'm sure we have all experienced at some point. Addressing the needs of LAP families is not only the right thing to do ethically, but data has also shown that it's the right thing to do medically. This study is a study out of Boston Children's Hospital that examined the incidence of both adverse events and preventable adverse events in hospitalized children from LAP families. The two major conclusions I want to highlight are noted in these two charts. Children of LAP families had higher odds of having one or more adverse and preventable adverse events when compared to children whose parents expressed comfort with English, even after adjusting for parent race, education, severity of illness, complex chronic conditions, length of stay, study site, and the intervention period. Overall, the study concluded that hospitalized children of parents expressing limited English proficiency were twice as likely to experience harms due to medical care, and recommended the implementation of targeted strategies to improve communication and safety for this vulnerable group of patients. The study prompted our multidisciplinary care team to examine interpreter use as a metric of health equity on an inpatient unit, specifically the ICU. And from this interest in health equity came the development and implementation of our novel communication bundle. Next slide. The name of our communication bundle is Unit-Based Pathways to Reduce Inequities for Families with Limited English Proficiency, also known as Uprise LEP. The name is meant to embody the ultimate goal of our project, which is to provide us, the healthcare providers, with the resources we need to rise up to the challenge of providing equitable care. But more important, the goal of the bundle was to provide LEP families with the resources and tools they need to uprise and advocate for their child and truly feel seen and be part of our team. The communication bundle was spearheaded by Jenny Magana Soto and Danny Ray Ardila and is now composed of the wonderful individuals you see listed here for you. Based on our collective shared experience, we determined that there are a number of barriers and limitations to providing language appropriate care to LEP families within our intensive care unit. In broad strokes, our communication bundle focuses on these three components, which is technological enhancement, staff education, and caregiver tools. Next slide, please. Our first component is new technology, and although it's my least favorite, I will spend a little time here because this is truly when we sat down and thought about, we thought this is truly the section where we hope to have the most critical impact on how our institution works to provide equitable care. This component involves identifying, monitoring, and measuring data related to LEP families and interpreter utilization. Although there already exist methods of capturing language preference on EPIC, as Shawn mentioned, we wanted to simplify the process of documenting the language preference and add in the additional information of being able to document communication preference. The effective identification of these patients allows us to more efficiently examine clinical data that is related to LEP families and therefore optimizes our ability and the ability of future researchers to evaluate a variety of clinical outcomes as part of health equity efforts. We also implemented tools in EPIC that allow us to more easily monitor interpreter use. This includes reconfiguring the node templates used to document interpreter sessions and working on creating a flow sheet that automatically captures interpreter use throughout the patient's course while they're in the ICU. By using technology to more easily identify and monitor LEP families, we aim to create automated EPIC reports that provide LEP-specific clinical data, such as time to ambulation, length of stay, and time to initiation of enteral feeds. These automated reports will allow for easy and sustainable patient outcome measures that could serve as the metrics included in a health equity dashboard and would therefore allow for a standardization of health equity dashboards throughout our entire Stanford institution. Next slide, please. Our staff education component is centered around teaching our staff how to best utilize the EPIC enhancements I just discussed, the resources and materials that the communication has added to our unit. The most exciting resource our communication bundle has implemented thus far is a unit-based interpreter. So most of our resources towards education have been centered on educating our staff on the processes that allow them to contact and schedule times with the interpreter who is solely based in our unit. Next slide, please. The last component is meant to directly address the point I made earlier about the title and core purpose of our communication bundle. I stated earlier that the main purpose of the bundle was to provide LEP families with the tools they need to uprise and advocate for their child. Therefore, we created a section in the bundle that focused solely on caregiver tools, and this was the funnest part of the communication bundle for me. We generated an orientation packet in Spanish that includes basic in-unit and hospital information to speak to the case that Dr. Marlow brought up. This would have been an orientation packet in this patient's preferred language that perhaps would have given her instructions on how to get to the cafeteria and how to ask for an interpreter. We also created small pocket interpreter cards that families can present to nursing when they need an interpreter in the case that their nurse does not speak their language. The last item was focused on our caregiver tools section, which is ultimately the best tool we could provide any LEP family with, encouragement. So we make sure to emphasize among our staff and our unit-based interpreters and everything that we do and implement with this communication bundle, that the point of this is truly to encourage families and make them feel that they can advocate for their patient or for their child and be part of the healthcare team. The current status of our project is currently still in its implementation phases. We've done most of our bundle. Obviously, the EPIC automated reports are taking some time, and we're so appreciative to our IT colleagues who have helped us out with this. We're excited about looking at the first phase of our data in the coming weeks, and we really appreciated the opportunity to showcase this as part of Health Equity Rounds.
Thank you, Dr. Ruiz. So now we'll pass it over to our guests, Dr. Platchek and Ben Enlinson from QI, and PI to share with us some innovations coming out of their shop.
Thanks, Baraka. So Ben and I both work within the Stanford Children's Center for Pediatric and Maternal Value. And as part of the past year, colleagues within our center have been looking and analyzing disparities, particularly as they relate to quality outcomes within our patient population. And for those that are engaged in quality improvement, they'll probably know the mnemonic SMART goals. It refers to goals that are specific, measurable, achievable, relevant, and time-bound. And one of the things that we're trying to do is incorporate the concept that Dr. Lena Kipps brought to the organization of smarter goals, which bring in equity revision into the conceptualization. We have a committee at the organization focused on our hospital-acquired conditions, and it's looking at the disparities based on race and based on preferred language, and it's trying to incorporate countermeasures to address them into our systems that aim to improve quality. Ben, anything else to add?
Just to reiterate our support for this work, and that our groups will be in touch with the Health Equity Rounds leadership team as requests for help come up. And so we look forward to partnering with you all in the year and years to come.
Thank you so much. We truly appreciate your partnership, and it's really exciting to see that many of the concepts that Dr. Wong explained to us about how we can apply QI to equity to assure that we're not exacerbating disparities, but narrowing them are already starting to happen here. Dr. Kameny, would you like to close us out?
Yes, so thanks for everyone for a beautiful presentation, and especially to Dr. Ruiz for presenting a QI initiative that's working to affect systems level change. But we also want to leave you with some things that you can do personally. And as we talked about before, implicit bias is something that happens more when we're using that fast systems one thinking. And so these are ways to transition your mindset and really use your systems two thinking. So the first is to really just pause and recognize that some of your impressions of a patient or a colleague may be because of implicit bias. And the second step to that is really stereotype replacement. And what we mean by that is, again, the pause and recognizing that your response is based on stereotype and labeling that emotion and reflecting on it, and then replacing it with an unbiased thought. And then also considering the patient or the family as an individual. As folks have talked about in this case, this mother, probably had the best of intentions for her child, as most of our families do. But the systems had sort of conspired against her to prevent her from being able to provide that care. Taking perspective, putting yourself in the position of your patient or family and understanding the barriers in that regard. And finally, going outside your comfort zone. And this means not just associating with friends or colleagues who are inside your in-group, but really reaching across and to associate with folks who are more in a different group from you. And that's a way to break down stereotypes. And all of these have been studied in the sociology literature as strategies that do impact implicit bias. And now I'll turn it over to Dr. Wong to discuss our efforts here at LPCH.
Thank you. So I hope we were able to illustrate today the importance of everyone working together, and we need your help. And so we really want to encourage people to try health equity rounds in their local settings. And then I also wanted to, as Dr. Floyd mentioned at the beginning of this presentation, just really express my gratitude for the leaders here at Stanford who have already been blazing the path for equity and health literacy. And so we really hope to be able to work with everyone together to advance this initiative. So for Dr. Kameny and myself, please contact us if any support is needed or you need any advice of how to get started. And then also our team will be working with local teams and the LIT and QI teams collaboratively.
So Health Equity Rounds is just one part of the 4 parts of our Health Equity Advanced Through Learning Initiative, or HEAL initiative in Stanford Pediatrics. We're really grounding in the fact that promoting health equity is each and every one of our jobs. It's all of our responsibility throughout our Department of Pediatrics, our clinical and non-clinical colleagues at LPCH and Stanford Children's Health, And it grounds a shared mission that we really can only achieve through collaborative effort. So first, the first offering is the HEAL Anti-Racism Seminar, which provides foundational knowledge in structural racism, medical racism, microaggressions, and effective allyship in hopes of bringing us all to the point where we can have these discussions in a more comfortable manner so we can have time to practice them. This is followed by the HEAL Email Challenge, which allows you to consume material that you can watch, read, or listen to and reflect on in order to accelerate your own anti-racism journey. Health equity rounds in local settings will be similar to this, but more interactive, and we'll work with our local improvement teams and QAPI teams for these discussions. And then with Huddle Guides, we plan to take key concepts from our HEAL Anti-Racism seminar and distill them down into bite-sized one-pagers that can be used in standing meetings or clinical huddles as a way to really assure that all of us around the bedside are working with the same foundational knowledge and have a similar approach around the bedside to advance health equity. As we have a few minutes for questions, we can pause here and open it up for questions, but I thank you so much for coming today and listening to us, and we really look forward to engaging with you as we move this work forward. So I see that there were several comments in the chat around some of the barriers of having in-person interpreters. And I know that one of the things that's happening on the hospital side in our DEI committee is a whole improvement project that's also focused on increasing access to in-person interpretation when it's necessary. So our hope is that through this work, through the work of the communication bundle, the marriage of these two things together can eventually get us to a point where this is a little bit easier. And then there's a question in the chat about how to get a unit-based interpreter. Liliana, do you have any insights around that?
Yes. So I think everybody has access to the interpreter tab on Epic, and that's how you request a, it's called a CRM for an in-person interpreter, and you can have, it depends on the type of session, but you can do a pre-scheduled session, which, you know, for example, teaching or care conferences, or the next available interpreter through the interpreter tab on Epic.
Thanks, Liliana. Michelle, you made a really good point about bundling patient safety culture with health equity, and that's really the goal through the work that Terry and Ben are doing. Terry, do you want to provide a little bit more detail around the work that you guys are advancing?
Sure, yeah, and I'll let Ben fill in where I might have knowledge gaps. But the broader quality agenda, so safety, don't hurt me, and quality, heal me. We in the past year have been looking, as I mentioned, amongst many different areas where there might be inequity, gender, race, or language, and we're trying to see where we might have outcomes that are disparate. We all, you know, talking about what we discussed at the beginning, the PDCA concept, we're applying those concepts and trying to see, though, what we think the root causes of these inequities are, and trying to address them. And as you mentioned, we have improvement structures set up across the organization, local improvement teams in certain areas. We have quality assurance and performance improvement QAPI systems in place to review our metrics and try to prioritize the improvements that we're looking for. And what we're trying to do is make sure that equity revision is part of all of those discussions. The methodology doesn't change, but what we hope is that we're addressing root causes that might be systematically promoting the disparity.
Thanks so much. Someone asked about the role of palliative care. I think as we think about this, rather than stepping back and thinking about just a role for one particular person, it's really thinking about, as we're all approaching our work, how do we figure out how to identify what a specific patient and family's needs and context are, and then applying whatever resources are necessary in order to get them to the optimal outcome. So rather than saying we're going to take a formulaic approach, we're really thinking about the population level as well as the individual level needs. And I think we have a few more minutes for questions, so you guys can keep those coming.
wanted to highlight, there was a comment in the chat about wanting to bring health equity rounds to other settings. And just as Cynthia mentioned, we're happy to help pilot that with you and partner with you in your environments to figure out how it could work out in your local setting. And that's definitely the goal of this.
So if you're interested, please email the three of us and we'll work with you and your local team to get health equity rounds up and running in your setting.
And then Dr. Floyd, I had one comment that I noticed in the chat about home visits. And so for dialysis, we're required actually to do home visits before starting home dialysis. And so we actually found that with the pandemic and doing telehealth, that telehealth was actually very useful for us to determine, resources that families needed beforehand. So I really appreciate the chat that was put in terms of home visits, because I think those could be really helpful in terms of helping determine what resources families need.
Cynthia, that's such a good point. As we think about telehealth in the primary care realm, one of the ways that it's been so helpful is for us to really be able to better understand a family's home context. So I can meet the patient and family members that don't get to come to visit, but that have very important roles in these kiddos' lives. I can see for an obesity visit where a patient's following up to talk about goals and nutrition. I can look at the size of their plates. I can see what's in their refrigerator. I can see what snacks they're eating. And it gives you a much better sense of where barriers might arise so that then you can make sure you're meeting your patient where they are.
I read on the questions about literacy and how to assess that. I think the interpreter is going to be your best buddy, your best tool and we are able to assess if they're able to understand, at what level they're able to understand. Even in the admission questions, they ask, what was the last grade of school that you attended, right? So that helps everybody understand where they stopped going to school. And so the interpreter is able to assess if they can read, if they can understand, or how well they can understand, if they can understand medical terminology, or if they're very well educated. It's also very important to note that it's infantilizing the parents, right? It's not good sometimes, because sometimes they do understand a lot. So the interpreter is your best resource to assess literacy in parents.
I'd actually like to piggyback off of what Liliana said, because I know from a case management perspective, I sort of wear two hats. I wear, the hat of a nurse and as well as the case manager. And I know it is common practice for nurses to perform teach back. And that is also a very effective way to assess literacy, because if we can get the family to repeat back to us what has been taught, we also can identify where there may have been gaps in their understanding or knowledge gaps and address those immediately so that they don't have consequences down the line as far as how they take care of the patient.
So I also wanted to piggyback on both of those, Shawn and Liliana. Thank you so much for bringing that up. And I realize that for assessing all the understanding for patients, it takes time. And so I admit I really utilize our nurses to help go back after I've talked to them to make sure they understand the instructions and also do teach back.
I wanted to highlight one question for Dr. Marlow in the chat around whether or not with this particular family, whether there was any further genetic testing and how is a sensitive topic like this addressed without coming off as racist or culturally insensitive?
Yeah, thank you for that question. Yes, this family has had a very thorough genetic evaluation, and they have now since been established with care with, again, many of our subspecialists. I think really using that trauma-informed care lens of kind of bringing up these very sensitive topics is really one of the best ways that we can have that conversation, which might seem difficult, but really keeping that perspective of we are here to help. We are not here to judge if there is consanguinity or really any of the experiences that they've had in their lives. And so with a respectful but very clear conversation, sitting down together, that's where we were able to identify the information necessary to get them to the subspecialty care that they needed. And so I really think it's trauma-informed care that can guide sensitive topics such as that.
Also, sorry, if I can mention one thing. I think one thing that I've really realized with the implementation of this communication bundle as a provider, and I like that Liliana kind of spoke to this, but is realizing, stopping and asking your interpreter what works best for them, or is there something you can do to help the conversation, and really thinking about the interpreter just the way you would think of your respiratory therapist or your PTOT, and that child's care will not move forward unless you involve this person. And so I really like the fact that she brought up the fact that they do have training on bringing up health literacy, because that's something that I've learned in the implementation and being more involved with interpreter services. And so I think stopping and asking them and seeing how you can help them and how they can help you before even meeting with the patient has been really helpful for me, and something I had never thought about as a provider.
Thank you, Dr. Ruiz. All right, as we round out the end of our session, I just want to again thank all of our leaders and panelists and presenters today, and our special guests for joining us. We really, really appreciate all of your engagement in this space, your wonderful questions, and we look forward to working with you as we move this work forward. Thank you so much.
Thank you, everybody. Congratulations on a great session.
The preceding program is copyrighted by the Board of Trustees of the Leland Stanford Junior University. Please visit us at med.stanford.edu.